All right, so let's continue on with the rest of the respiratory PowerPoint. So meconium aspiration syndrome. So what's going on with this? Something caused the baby to stool either while in utero or during the delivery process, and they were under some kind of hypoxic stress, which then caused them to inhale the meconium stool into their lungs. So, risk factors: post-term birth, breech, forceps or vacuum delivery, prolonged labor, fetal distress, infection, placental insufficiency, maternal hypertension, preeclampsia, oligohydramnios, drug abuse of the mother. So all of these things can lead to fetal distress or stress in the utero. They can also lead to hypoxia. Okay, and what do we all do when we're hypoxic? We try to take a deep breath. So these babies have poor gas exchange, so they take that deep breath. They end up sucking in some stool into their lungs, which then causes respiratory distress syndrome. It can in turn lead to persistent pulmonary hypertension. It can also lead to right to left shunting of the blood because that patent ductus arteriosus needs to stay open. I'm hoping you all know what MECA is. Remember, it's that thick, tarry first stools of babies. That is a formulation of amniotic fluid and anything the baby has digested in utero. These babies, when they're born, one thing that we can see is during the delivery process when the amniotic sac ruptures, is we will see that it is MEC stained. We can also see that their nails, their skin, and the umbilical cord, if they've been floating around in the stool for a while, will be stained that greenish brown color. These kids will have respiratory distress, so they will have a barrel-shaped chest. They will be tachypnic or have tachypnea. They're going to have intercostal retractions. They're going to have grunting, cyanosis, among other things. We're going to see all that accessory muscle use. We're going to see a little bit faster heart rates, unless they are severely distressed and they are severely compromised. We're going to do ABGs, and we're going to see metabolic acidosis. What else are we going to see on them? We are going to see they're easily stressed. They sometimes will have poor perfusion. Their blood sugars could be off. Okay, so we're going to do good respiratory assessments, cardiac assessments. We're going to get that baby warm and have cluster cares, decreased stimuli. We're going to do CBCs and CRPs. I'm trying to think that electrolytes. So some things that we will have to watch on them is suctioning at birth. We don't want to deep suction them. So we might suction their nose and just their mouth. If we find we have to deep suction them, we will intubate to deep suction. We don't want to do a lot of suctioning with these babies because that can be overstimulating, and therefore when they overstimulate, they could suck more of that stuff into their lungs. We're going to decrease their oxygen demand. So humidified O2, we typically will give them surfactants, so we'll eventually end up intubating them. If they're under a lot of fetal distress, it is not uncommon for us to, these babies can be severely sick, so we will go ahead and sometimes sedate them. We will give vasopressors, pulmonary dilators. They will be intubated. We do use ECMO on these kids sometimes, extracorporeal membrane oxygenation. We're going to keep them warm. We are going to educate the parents and talk to them. Just close monitoring. Okay. So this is a concept map on persistent pulmonary hypertension, or not persistent pulmonary hypertension, MEC aspirate. So what it kind of gives you an idea that how MEC aspirate can lead to persistent pulmonary hypertension, but also some other things that are going on. So meconium passage, they're hypoxic. The baby takes that first breath, sucks some of this stuff in. Then they can have obstruction, impaired surfactant, and pneumonia. That can lead to air trapping, atelectasis, the impaired gas exchange. They end up with pulmonary vasoconstriction, and then that leads to persistent pulmonary hypertension. The kids that end up with persistent pulmonary hypertension, well, they have a MEC aspirate. Those kids are the ones that are sicker, that typically will be on ECMO or even just plain sedated with a ventilator. All right, persistent pulmonary hypertension. This is a pulmonary vasoconstriction that occurs in the baby that leads to vascular resistance of the lungs. We see this in term babies and post-term babies. This is associated with hypoxemia and acidosis, and that is due to asphyxia, that MEC aspirate we were just talking about, sepsis, polycythemia, diaphragmatic hernias, and severe respiratory distress. They become tachypnic within the first 12 hours after birth. We see that cyanosis, grunting, and retractions. When we listen to their heart, we're going to hear that murmur, and that's that PDA that's still opening, and that's allowing for a right to left shunt of the blood. To diagnose it, we need to use that echocardiogram to tell us that this is what's going on. We're going to do good oxygen monitoring and perfusion, watch their blood pressure. So we're going to relieve that pulmonary vasoconstriction by giving them vasodilators. These kids tend to be sedated, high frequency ventilation. We will give them surfactant. We use a lot of nitric oxide because that helps dilate that pulmonary vessels and opening things up and ease the respiratory issues. We cluster their cares, low stim environment. These babies typically aren't held right away. Same with some of those severe MEC aspirate babies. Clustering of those cares, frequent vitals. These are kids that are, at first, their vitals are done sometimes hourly, at least by the monitor hourly, and maybe it's Q2 by nurse. And then that head-to-toe assessment is done either Q2 or Q4 by the nurse, and then it's just visual all the other times. These kids can grow out of their persistent pulmonary hypertension, but then it can be a lifelong thing. I do know of 2 kids, just because I know their families, who had severe persistent pulmonary hypertension when they were in the NICU. The one little girl is older than Caitlin. I can't remember. She's in her teens now. Can't remember if she's 13, 14. She is going to die from her persistent pulmonary hypertension, and and they've tried everything to help her. Another little guy that I know, he's in elementary school, first grade, second grade. He also has had persistent pulmonary hypertension about 2 years ago, I want to say it was, when he went in for his follow-up at checkups. His persistent pulmonary hypertension was gone. He will still go in for, I believe, yearly or bi-yearly appointments just to make sure he's doing well. So these kids can grow out of it, and it can also be a lifelong issue. All right, bronchopulmonary dysplasia. This is chronic lung disease. These kids have lung injuries, or they need a continued oxygen after the initial 28 days of life. So when you think about it, a baby that has been needed to be ventilated for like more than a couple weeks of life could end up having severe lung damage. They have a prolonged dependency on O2. Kids that have a surfactant deficiency due to infection, RDS, prematurity, MEC-aspirate, these things that we've been talking about can end up with become BPDers, or bronchopulmonary dysplasia. They can end up having severe pulmonary edema. Their lungs are severely immature, or could be severely immature. They can end up with barotrauma because of being mechanically ventilated. That mechanical ventilation is forcing those alveoli to stay open. But also, if you think about it, if those babies need to be intubated, extubated, intubated, that trauma that we're doing by putting in those endotracheal tubes can also cause that trauma, the edema, and everything like that. Fluid overload. Fluid overload due to holding on to fluids. We're having to push fluids. Persistent pulmonary hypertension. My kids on ECMO end up getting fluid overloaded. And where does that overloaded fluid go? To the lungs. Let's see. Some assessment with bronchopulmonary dysplasia. Risk factors, let's start with that. Boys, males, Caucasian male, babies born under 32 weeks, babies that are having a nutritional deficiency either due to the prenatal environment or post-delivery, not watching that fluid intake too well, and we're pushing too many fluids in those babies, babies with a patent ductus arteriosus or a PDA, severe respiratory distress, needing mechanical ventilation for greater than 1 week at a time, and infection. These babies will be tachypnic, have poor weight gain, they'll be tachycardic, they'll have sternal retractions, nasal flaring, bronchial spasm, so we'll hear crackles and wheezing, and their blood gases usually show that they're hypoxic. So what do we do for these kids? Well, one thing is they need that continuous ventilatory support and oxygen support. So we are going to slowly wean their oxygen settings and their ventilator settings, and we're going to take things slow, because if we push things too fast, then if the baby has a setback, we have to go back to extremes, so like re-intubating them. And what does that do? That causes trauma. We'll give them good nutrition. These kids end up having to have higher calorie feedings. We give them bronchodilators, diuretics to pull that fluid off of them, antibiotics, close respiratory assessments, lots of education to the family and the children, or in the family and anybody around. These kids end up, because of being prolonged intubated, they can end up with problems eating, with oral aversions, because they've had a lot of negative stimuli to their oral cavity. So oral feedings, we end up slowly introducing. When we know that they can handle it, we start giving them drops of milk with a pacifier so that they start having positive oral stimulation. These kids sometimes end up with G-tubes due to that poor oral feeding. These kids, because of that trauma to their airway, some will go home on oxygen a lot of the times, but they will also be kids that are going to be at higher risk for asthma and long-term respiratory issues. Okay, newborns of substance abusing moms. I have supplemental readings for you guys that I will bring to class on Tuesday. So, common substances that babies can withdraw from: tobacco, alcohol, marijuana, meth, which is common in our area, unfortunately. What else besides meth? Coke, methadone. I've seen that one a lot, unfortunately. They used to believe marijuana was one of the least severe drugs for babies to be withdrawing from, and now with more research, they're finding these kids are having issues with that. Fetal alcohol syndrome. This is moms that drink a decent amount of alcohol during that early part of pregnancy, but also during the full pregnancy. It can lead to physical and mental disorders in these babies. Some of those disorders are that microcephaly, small eyes, intrauterine growth restriction or retardation, flattened nares or flattened bridge on their nose, epicanthal folds, thin upper lip, their nose sometimes is upturned, joint and limb defects, lower birth weight. They can have changes in their palmar creases, congenital cardiac defects, poor hand-eye coordination, narrow forehead, intellectual disabilities, hyperactivity, social issues, thin upper lip. So a bunch of different things. The supplemental readings I have gives you a really good list of those things. What else do we have? Neonatal abstinence syndrome. This is the syndrome these babies are going through when they're withdrawing from the drug dependency that they acquired during utero. They can cause physical and neurological disorders in these babies. Even moms that are on prolonged meds during the delivery process, those kids can withdraw from those things. They may not end up with long-term issues, but they could have that initial neonatal withdrawal stuff. Labs, we're going to run for drugs. We're going to run for toxicities. We're going to do CBCs, CRPs. We'll also do genetics on these kids, especially if we are worried about neurologic issues, to rule out everything else. We'll do, if they're having respiratory problems, we'll do blood gases, infection, things like that. Oops, sorry. All right, so some of the assessment pieces, besides recognizing the things that we will see in those kids with fetal alcohol syndrome, which this little guy in this picture has, you're going to see the withdrawal symptoms. So you're going to see some neurologic behaviors. This box 24.3 is in the supplemental readings I'll hand out to you guys. I like the withdrawal acronym. These kids are going to have wakefulness. They barely sleep, less than 3 hours after feedings. I took care of a couple of kids that only slept for 15 minutes every 3 hours. Irritability, temperature variation, tachycardia, and tremors. Hyperactivity, a high-pitched, persistent cry, hyper reflexes, and hypertone. They have diarrhea, diaphoresis or sweating, and they have a disorganized suck. Their suck swallow is fine, but it's disorganized, so they don't eat well. Respiratory distress, rub marks because they're constantly moving, rhinorrhea or stuffy nose. They can have apnea attacks or that autonomic dysfunction, so poor transitions. They can have weight loss or failure to gain weight. They can have alkalosis, respiratory alkalosis, and lacrimation or tears. These kids can have seizures, fast heart rates, sneezing. Okay. So what do we do for these kids? We are going to keep them calm. We are going to promote good nutrition. We will give them medications to slow down their withdrawal. It is not uncommon for us to maybe put these kids on a morphine drip and then slowly wean them to ease their withdrawal symptoms versus being born and having everything taken away. We will swaddle these babies, pacifiers. We'll do good assessment. So these kids will sometimes have bulging fontanelles because of the neurostatus of them crying and being agitated. So good assessment pieces. We will work with them on feeding. So these kids sometimes will be on NG feeds for a while. We will work with the parents because a lot of the times the parents get to take these kids home. So we will help the parents learn how to cycle the light and taking care of them with cares. So I slowly do my cares versus abruptly doing things. So don't flip on the lights. Don't quickly undress the baby. So taking slow steps. Boundaries. These babies sometimes do better with simple movements, so we will get beds that have simple non-jerky movements or even swings that don't jerk a lot, that are just smooth movements. Low music, sometimes no music. Clustering of cares, quiet environment. These kids can be withdrawing for a long time, and therefore they end up in the hospital for longer periods of time due to the withdrawal. On the East Coast and the West Coast, they actually have NICUs that are specific for kids that are withdrawing, and therefore we end up having the moms and the moms and or dads move in to the unit, and the nurses that are there 24 hours a day helping the parents learn how to care. I have lots of stories along these lines, but for time constraints with our presentation, I'm not going to get into them, but fetal alcohol syndrome is something that we can't fully diagnose until that child is older. We can have those suspicions. So a lot of support of the families. I think this is one of the hardest ones that I've had to deal with, but I've learned to be understanding and work with those parents. I'm very blunt with some of the things without saying you're an idiot or it's your fault, but I'll be very blunt in saying your baby is withdrawing from substances it was exposed to. So I'm saying it how it is without pointing my fingers while I'm working with the parents. But I'm also very supportive of the parents because they need that, especially when they're going through their own treatments, because they really do want to keep those babies and help those babies. All right, our last topic, last 2 slides. Neonatal infections. There's lots of neonatal infections. CMV, herpes, just colds, things like that. All these respiratory issues, bacterial, fungals, congenital, at early onset. We usually see signs and symptoms of these within the first 24 to 48 hours after birth. They progress very rapidly. They have a high mortality rate. This could be due to E. coli in the vagina. This could also be like Canada's herpes and chlamydias. It is associated with obstetric events such as preterm labor, prolonged rupture of membranes for longer than 18 hours, moms that had fever while in labor, and chorioamnitis. Late onset infections usually occur after around day of life 7 to 30. These can be due to Staphylococcus, Klebsiellas, E. coli, Pseudomonas, or Candidas. These can also be MRSA and VREs. They can occur at the umbilical stump, mucous membranes of the eyes, nose, and pharynx and ears. This can be due to kissing those kids when you're sick. Sepsis does occur twice as often and has higher mortality rates in males with late onset factors. In my assessment, I'm going to do a good head-to-toe assessment on those kids, doing respiratory assessments. A lot of the times, sometimes that will be the first thing that we see is wrong with these kids. We will do CRPs, blood cultures. As we're waiting for those results back, we will go ahead and start these kids on antibiotics right away because we can't wait for those things to grow. It is not uncommon for us to also do lumbar punctures, things like that. If that amniotic fluid smells funny or seems off, we'll go ahead and run all these labs as well on these babies. These kids will sometimes have poor feeding, poor weight gain, lethargy. We might see rashes, that respiratory distress, changes in their color, irritability. So antibiotic therapy, it does depend on the type of antibiotic. At least 7 to 10 days. Things like herpes and infections like that. Sometimes it's 21 days of antibiotics. Blood cultures, cerebrospinal fluid, stool and urine, CBCs. We're going to watch for septic shock because these babies get sick quickly. So those would be signs of decreasing O2, poor perfusion, tachypnea, respiratory distress, hypotension, signs of meningitis or DIC. We want to make sure to prevent infections from going on. That's why we do screenings in the NICUs in the hospital. We will do good hand hygiene and oral care on those babies. We reposition them frequently depending on what their requirements are. So if they're super preemies, we may not rotate them as much. Aseptic technique whenever we're doing a lot of our cares, cleaning equipment with each shift. Very rigorous on when we change out equipment. Close observation of the children, things like that. We teach parents to monitor their house. Don't let people come in. Make sure people are washing their hands. All of those kind of things. We will review in class on Tuesday. Fingers crossed we don't have another snow day. And we'll have a good weekend.